Excessive drinking kills 178,000 Americans every year. Over the last few years, those fatalities have spiked by 30. Only 1 in 17 patients with a documented alcohol use disorder receives evidence-based treatment, compared to 1 in 14 for opioid use disorder. Even among the narrow slice of patients with an alcohol use disorder who actively seek formal treatment, fewer than 10% are prescribed FDA-approved medications. The medical system's current standard of care severely underestimates the acute medical risks of alcohol cessation, treating a dangerous neurological crisis as a simple behavioral issue. Over time, chronic alcohol exposure forces the brain's circuitry to physically restructure and rewire itself to maintain a functioning baseline. This allostatic shift alters the brain's balance. Alcohol enhances inhibitory GABA signaling. To counterbalance, the brain suppresses excitatory signals, downregulating NMDA receptors. When drinking stops, alcohol leaves, but adaptations remain. The brain is suddenly flooded with unregulated glutamate, unmasking a profoundly hyperexcitable neural environment. This electrical hyperexcitability drives the immediate clinical presentation. Patients experience severe tremors, autonomic instability, and the onset of life-threatening seizures within 8 to 48 hours of their last drink. The danger compounds over time through a neurological process called kindling. Each subsequent withdrawal episode permanently sensitizes the central nervous system, increasing the severity and seizure risk of all future episodes. Because alcohol dependence is driven by structural neurotoxicity and severe receptor dysregulation, attempting a non-medical, behavioral-only detoxification is a lethal clinical error. Despite this low utilization, highly efficacious FDA-approved pharmacotherapies exist to manage this condition. These medications are specifically designed to directly intervene in the disrupted GABA and glutamate circuits. A comprehensive review published in the European Journal of Clinical and Experimental Medicine evaluated the data. The researchers focused strictly on clinical trials lasting 12 weeks or longer to ensure long-term behavioral reliability. Here, the researchers utilized a network meta-analysis. This is a statistical technique that allows for the simultaneous comparison of multiple different treatments against each other and against a placebo. This forest plot charts exact risk ratios. Acamprosate scored 0.87 and naltrexone 0.93, proving both reduce relapse risk versus placebo. Naltrexone acts as a neurobiological brake, uniquely proven effective at reducing a return to heavy drinking. To determine the absolute best clinical option, researchers used a SUCRA score. This ranking places the acamprosate and naltrexone combination therapy at the very top with a near-perfect 0.99. Combining the two medications yields a statistically superior therapeutic outcome because it attacks the disease from two angles, neutralizing the reward pathway while simultaneously stabilizing the withdrawal neuropathways. These results heavily contrast with disulfiram, an older medication that induces physical sickness when mixed with alcohol. Disulfiram requires intense compliance monitoring and showed no statistically significant benefit over a placebo in standard clinical settings. With a treatment gap exceeding 90%, the failure to treat alcohol use disorder is not a limitation of pharmacology or medical science. It is a failure of systemic implementation. Looking at this data-driven map visualization, we can see exactly where that implementation breaks down, a stark urban-rural divide. Rural populations experience significantly higher rates of heavy episodic drinking and alcohol-related mortality, yet they report receiving treatment at half the rate of urban areas. The physical infrastructure simply does not exist. Nearly 3/4 of rural United States veterans live in counties completely lacking a practicing psychiatrist. Without specialty providers, these regions lack the specialized clinics equipped to prescribe the FDA-approved medications that stabilize alcohol dependence. This limited infrastructure forces rural residents into the court-mandated treatment pipeline at much higher rates, frequently because a lack of safe public transportation or ride-shares leads to impaired driving. Sociocultural barriers compound these structural deficits. In close-knit communities, the reputational risks and extreme privacy concerns associated with seeking addiction treatment are severe. Patients actively avoid care due to fears that local medical transport drivers or general practitioners might share sensitive substance use data with overlapping social circles. The current medical model requires traveling to specialized addiction psychiatrists. This structure actively repels the most vulnerable, isolated demographics from seeking the care they need. Beyond geography, a primary person-level barrier suppresses treatment-seeking rates across all demographics, the historical, systemic mandate for total abstinence. The abstinence-only framework misaligns with the goals of most patients, many of whom want to reduce their intake without committing to permanent cessation. Many patients recognize their hazardous drinking patterns, but actively avoid physicians out of fear they will be forced into an immediate, specialized detox program. This line graph comparing patient retention rates over time shows why that model fails. Non-abstinent harm reduction strategies yield equivalent reductions in alcohol consumption and negative consequences, while maintaining steady, long-term patient engagement, compared to the steep drop-off in abstinence-only protocols. Adapting the clinical approach to match the patient's actual goal, like conditional abstinence or controlled low-risk drinking, is a highly accurate predictor of long-term treatment success. Medications like acamprosate and naltrexone are well suited for these harm reduction goals. They allow patients to regain neurobiological control without requiring immediate total cessation. By clinging to an outdated, abstinence-only specialty model, the medical community inadvertently denies life-saving neuropharmacology to millions of individuals who would otherwise seek help. To solve this, the Substance Abuse and Mental Health Services Administration's TIP 49 protocol outlines a clear solution: move alcohol management out of isolated specialty centers and directly into general primary care. The first required step is normalizing systematic, universal screening during standard medical visits. This is done using validated tools like the audit, the Alcohol Use Disorders Identification Test. This flowchart visualizes the framework for general practitioners, known as SBIRT: screening, brief intervention, and referral to treatment. The brief intervention phase is critical. It allows physicians to establish harm reduction goals and prescribe medications directly without escalating to a specialty rehab referral. Empowering primary care doctors to directly prescribe these medications allows the medical system to intervene at earlier, less severe stages of the brain's allostatic shift. To close the geographic access gap, clinics can utilize telehealth platforms and mobile applications to deliver both the pharmacotherapy prescriptions and the routine behavioral check-ins. Remote prescribing directly neutralizes the privacy fears and transportation barriers that currently cripple rural treatment rates. Under this model, specialty referrals are strictly reserved for highly complex cases, rather than acting as the default bottleneck for every single patient. Defeating the alcohol mortality crisis requires clinicians to view alcohol dependence not as a behavioral failure requiring isolation, but as a treatable neurobiological condition entirely manageable within routine medical care.